Thank you for that warm welcome. And we're going to see who can spell aberrometry.
Yeah.
The ABCs. So I'm glad to see so many people live. The memo I got yesterday was that there were going to be many remote. So hopefully we're checking that we're projecting well to those remote people as well.
Yep.
Right? Okay, good. So what I'd like to do for the next 25 minutes is just spend some time sharing with you the components of a comprehensive exam, which most of you probably know every bit as well as I do. You certainly know the pre-testing components better than I do. But I'd like to spin that into something that we do for, diabetic patients. And what are some of the components with our diabetics that we look at in particular, and things to watch for and trends that you may see as you're working with patients as well. So just by way of some introductory things, I have no financial disclosures, except that I am paid to be an optometrist that does eye exams. So I suppose that might be somewhat of a conflict. But we'll spend some time looking at reviewing the ocular anatomy, identifying components of what we do for a comprehensive exam, look at some of the mechanisms of diabetes, and what impact they may have on patients' ophthalmic status. So we'll look both refractively as well as medically and health-wise. What are the consequences of poor control? What can happen to patients who don't take it seriously? And then look at the overall impact of diabetic disease. So if we start out by looking at the anatomy, we're starting from the outside in. So we know that the precorneal tear film is the first layer that we encounter, but we don't lose sight of the fact that tears are not just salt water, right? I mean, there's a lot to them. There's lipid components, there's lots of proteins and lysozyme and lots of things in the tear film that not only help to resist things like allergies and infections, but also that creates that initial refractive surface for the eye, which does about 70% of the overall focusing. So recognize that the tear film is a complex component, and that's why we see a lot of new artificial tear supplements coming out that seem to be different. They're trying to find ways to mimic that complex tear film more closely. And then if we look at the things that control the tear film, the lids, the lacrimal gland, and the drainage apparatus, again, I'm sure you're all familiar with these things, but sometimes we lose sight of the importance of these and how that can change how patients function. If patients get dry, their vision can be impacted. They can be uncomfortable. They can be red. They can have discharge, et cetera, et cetera. And all of the lids and adnexa go into that. So you may see sometimes that we're prescribing agents like Restasis and Xiidra that actually stimulate the lacrimal gland to produce more of the natural tears for the eyes. You may also see us do things like punctal occlusion, which actually decreases the outflow of tears. So different mechanisms to try and keep that tear film both plentiful and of good quality as well. Looking from the left to the right, obviously corneal surface, we talked about that being a primary refracting surface for the eye. As we come through the iris and pupil, we hit the crystalline lens. We know that does probably about 20 to 25% of the overall focusing for the eye. And then some of the things that we'll talk about later, and we'll close up the talk today with looking at some of the impacts that diabetes can have on the posterior segment. So the retina itself is a very highly metabolically active tissue, which is why it has such a rich vascular supply to it, both from the choroid on the external aspect of the retina and on the retinal vasculature that nourishes basically the inner 2/3 of the retina. And you can see from the image here that those vessels emanate from the optic nerve and then they spread around. Those of you that are involved in diagnostic testing and do a lot of posterior segment imaging, this will be very, very familiar to you. I'd like to take just a minute to look at and focus on the drainage area. And we know that the aqueous is produced by the ciliary body. It flows between the iris and the lens through the pupil. And as you can follow that green arrow, it then drains out in the anterior chamber angle. All right. So I wanted to show you representatively what that normal system looks like so that later in the talk, when we look at what breaks down sometimes, I'll have you hearken back to this and just look at that and say, kind of remember, okay, this is what happens. it goes through the angle, and then you'll see that it actually will flow through these emissaries, which come out of Schlemm's canal, and then it actually links back up with our venous system and gets back into the circulatory system. So the aqueous produced here by the ciliary processes flows through along this green arrow through the pupil and out to the drainage area. Just keep that in mind for later in the talk. If we look at the corneal surface and as much refracting as it does, it poses some problems to us. One good thing is that it's transparent. We can look through it to examine the eye. One bad thing is because it has such high refractive properties, we can't look toward the angle and see without internal reflection causing problems. So that's where we, if you're familiar with gonio lenses, on the left-hand side of the slide there, these are lenses that we can put up against the corneal surface and neutralize that internal refractive component of the cornea, and basically with a series of mirrors or prisms, look into the chamber area directly. So this is the only way we can view these structures that you see here on the right-hand side of the slide. These structures are all angle structures, and that's where the fluid drains out. And so Schwalbe's line, scleral spur, trabecular meshwork, kind of the mesh that the fluid percolates through. And then you can actually see in some eyes that have what we call deep angles, deep anterior chamber depths, or wide open anterior chamber angles, we can actually view the ciliary body, but only when we place one of these lenses on the eye. These do come in different forms, and you probably have seen that when we ask for gonio lenses to be brought. You may see that there's different types. Some have handles on them, some don't. People have their own preferences. Sometimes they'll use goniosol, sometimes they won't need goniosol. So don't let that confuse you. And then in the back of the eye, of course, we have structures like the optic nerve represented here. You can see, as we talked about earlier, that vascular system comes right out the center of that nerve, and it branches into venules and arteries that will then nourish the inner 2/3 of the retina. So we'll look at the impact that diabetes can have on these vessels, on the retinal tissue itself, and also we'll finish up by looking at some of the things that it can do to the macular area. Just a quick note, as I'm sure you're all aware, the central part of the retina, the fovea, is full of cones and therefore has all the detailed vision and all the color vision to it. So the peripheral retina, even though it can be affected with diabetes, does not always have the same impact on visual acuity as we measure it in the office. So what are the things that we need as part of our history and our workup? Obviously, we always need to know what patients' presenting complaints are. Is there any sort of systemic family ocular health history, pertinent surgical history? If they are diabetic, what is the nature of their diabetic disease? You know, are they pre-diabetic? Maybe they're a little overweight. Maybe they're not. They lead a very sedentary lifestyle. We know that those things all have impact on overall sugar levels. So some people will come in and say, well, I'm not really diabetic, but you might see that their primary care lists on there that we're watching them carefully for diabetic disease. Some folks become diabetic as they're pregnant, just during their gestational years. That does increase their risk of developing diabetes later on in life. So that's good to note. Are they using insulin or not? Are they just using oral agents? Do they have a pump? And what is the duration of their disease? Because as the duration increases, so does the risk for ocular complications. Typically, we can have level controls. The benefit of obviously being in part of the big university and have primary care networks is that oftentimes we can pull their lab works and we can actually see what their recent A1C is or what their blood glucose levels are, and include that in the chart as just kind of another metric. And then, of course, we want to know, are they having any sort of specific visual complaints? Have they had any refractive error change? Are they not seeing as well? Is it precipitous? Is it slow over time? Because especially for our newly diagnosed diabetics, or those that are really outside of proper control, sometimes we can see refractive error shifts as well. So as part of your visual acuity workup, of course, you check aided and unaided distance vision, pinhole if they're less than 20/40. Near vision is good to note if there's any distance that they want to hold it at other than a typical 13 to 16-inch distance. Some people might want to hold it real close to read that. And some people may want to push it further out at arm's length. That's fine. Just make notation of if it's not close to 16 inches. I also like to have included in there the condition of the correcting spectacles that they have, because sometimes people's acuity will be down 20/30, 20/50. We run their refraction, there's no real change. And yet I pick up their glasses and I look at them and they're all crazed or heavily scratched or so forth. So that's good to put just in the note to say, this patient presented with a pair of glasses and we checked their acuity with a pair of glasses that were pretty beat up. Very important to note postoperatively as well what their distance acuity is and what their near vision acuity is during the post-op cataract phase, particularly if it's a premium IOL. If it's a toric IOL or a multifocal IOL, that's of particular importance to us. We know that the eyes are controlled by 6 extraocular muscles, and those muscles are controlled by 3 cranial nerves. And so that can be important, especially in diabetic disease, which tends to be a disease of microvasculature. So very, very small vessels can be affected first. And there's a lot of very small vessels that affect both the nuclear control centers for these nerves and the muscles themselves. So we can have infarcts from diabetes where there's poor circulation, and therefore one or multiple of these muscles may be involved. This is basically what you're all looking at if you're working pre-testing patients, and you're basically looking at their extraocular motilities. In one fashion or another, you're asking them basically to excite those muscles and move the eyes in all these different directions. So I always marvel when people actually don't complain of double vision, because when you stop and think of everything that's going on here between all the nerve impulses and the muscles, and 6 muscles moving in the right eye and 6 muscles moving in the left eye, and they all have to coordinate with each other for us to remain binocular. Confrontation fields, obviously you're all familiar with. You all do a great job of doing this and collecting data for us to make sure that their cranial nerve 2 is intact. This checks their optic nerve. And pupil responses, looking for afferent pupillary defects. So this can oftentimes be very confusing. With more experience, it gets easier. Good to be done in low light conditions. And it's basically a swinging flashlight test that tells us, is there a reduction in the input or a decrease in the input down one optic nerve relative to the other. Diagnostic testing, again, those that are involved, we're very grateful to have those that are involved in our diagnostic testing centers, because most of us as providers would not know which button to push to run any of these tests or capture any of this information, but the information we get back is critically important. So we're very, very appreciative of all the things that you do for us to prevent this data, so that we can then make decisions on how to treat our patients and help with their diagnosis. So particularly in our diabetic patient population, what goes wrong? What are the things that we see? What are the things that we watch for? What are the things that you may see as you're working up patients and you notice that their vision's reduced and the things that they complain about? As I alluded to earlier on, if their blood glucose gets out of control, it can actually affect what their refractive error is. This is generally a transient change. So in other words, if their blood glucose is way out of control for long periods of time, they'll have a shift, but hopefully over time they right the ship, they get their blood glucose under control, and in a period of time that we would expect that would come back closer to baseline. There are cataracts that can develop obviously just throughout life, but in particular, we see some peculiar type of cataracts that tend to develop in our diabetic population. We can see leakage of the vessels, hemorrhages and exudates in the retina. We can see swelling in the macular area, diabetic macular edema, and poor circulation, basically, or ischemic disease in the retina as well as a consequence. I wanted to share with you a study that I came across that looked at this refractive error shift issue, and they looked at 20 newly diagnosed diabetics. Because we've long known that refractive error shift is a potential consequence of poor diabetic control. But how does it shift, and how much does it shift, and in what direction does it shift? And the fact is, sometimes it's in either direction. They can become more hyperopic or they can become more myopic. And so why is that? So this study basically looked at 20 newly diagnosed diabetics, looked at a variety of issues to make sure that they were ruling out the fact that it could be, corneal edema or corneal curvature changes. What is it that really changes? This particular study found that the hyperopic change, it was all hyperopic in all 40 of these eyes. And the hyperopic change was not insignificant. It was, on average 1.6 and as much as 3.2. So patients can come in and typically what will happen if they'll complain that their close vision is not as good as it was. And depending on their age and whether they're presbyopic or not, that can be a different story. But oftentimes you may see people coming in saying, well, geez, I grabbed my spouse's reading glasses and now they help me see better in the distance. So they can be confused by that. But the mechanism by which that occurs is not, really well understood. There's some hypotheses out there that I'll share with you that basically includes the fact that, as you can imagine, their blood glucose is high. So we know that the glucose serum levels are high, and those glucose levels can actually build up in the crystalline lens as well, which has no vasculature. The crystalline lens has no blood vessels. So if the glucose builds up in the crystalline lens, it's then converted to sorbitol, which has an osmotic imbalance and pulls fluid within the lens. And so in an osmotic fashion, it pulls fluid into the lens swells, and that would give a myopic shift. That would make the lens more plus powered, which means you'd have to compensate for that with more negative power in the refractive correction. But also there's a hypothesis that it can affect the refractive index of that lens as well, in which case the lens may become less powerful and therefore they need more plus power now in their glasses. Generally speaking, if they right the ship and they get their blood glucose under control, this can restore, it's not going to change overnight, but over the ensuing weeks, somewhere between 2 to 4 to maybe 6 weeks, they'll return typically to baseline. So we always tell patients, it's great that your blood glucose is under control, but if it's just a recent improvement, we probably don't want to prescribe spectacles for you just yet. We might bring you back in 2 or 3 months and then see where your refractive status is. So this basically just outlines in more detail than you probably would ever want to know that there are enzymes involved in this process that converts basically glucose to sorbitol and to fructose. And these things can have osmotic balances and also can create stress on the cells and actually sometimes cause death to the cells that are within the lens fibers itself, which can then lead to diabetic cataracts. So the osmotic hypothesis states that, like we said earlier with refractive error, the sorbitol is within the lens. Sorbitol comes into the lens, it draws fluid into the lens through osmosis, and that can cause destruction, physical destruction to the lens fibers itself. Remember, the crystalline lens is made up of lots and lots of fibers and continues to grow throughout one's life. So that's why everybody develops cataract over time, because that lens is actually getting thicker in an anterior to posterior fashion and therefore losing transparency. There can also be osmotic stress that can result in what we call apoptosis, or actually death of the lens fibers. And then that can lead to opacities because these lens fibers are actually perishing within the capsule. Remember that lens is in a privileged environment. It doesn't have any circulation. It's got no vasculature to it, and it's enclosed within its capsule. And so that lens and the proteins that are within that lens are kind of in a privileged site. They're separate from the rest of the components of the eyes. So as I alluded to earlier, we do have some uniqueness to some of these cataracts that we'll look at. Cataract, basically, anytime there's a departure from pure transparency in the lens, that's coined a cataract. And it can take on a variety of factors. We see a lot of times you might hear terms like nuclear sclerosis or NS. That's kind of a yellowing or a browning of the lens where they lose color sometimes from that. It shifts the color, the wavelength of the eye. We can have cortical changes that can come in a fashion of just kind of uniform white of the cataract, or even spokes that'll happen sometimes. You can get little vacuoles that develop within the lens. So these are all considered cataracts, but different types of cataracts. In diabetics, we tend to see either the snowflake type cataract, and you can see where that gets its name. It's pretty obvious. but very spotty. And this can create a lot of light scatter. And so people will complain about, the sun low on the horizon coming at them. They have glare symptoms, or if they're out driving after dark, the headlights and the street lights seem to be problematic as well. The other slide on the right-hand side here, you see this kind of granular appearance, and this is very typical of a subcapsular cataract, which can be either anterior, less commonly, or posterior subcapsular, which is more common. And it's almost as if, somebody took a handful of salt or a handful of sand and threw it up against a sticky, tacky paper. It has this very granular appearance to it, but it's, if you can appreciate looking from the front part of the lens here, this is a cornea over here, this band. This is the front of the lens. Here's the lens thickness, and all the way in the back of the lens, right along the back capsule, is where you see those posterior subcapsular cataracts. So they may not be as thick as some of the other cataracts, but they can be equally visually disturbing just by their very nature. We talked before about checking extraocular muscle motilities and why that's important, and what comprises that between the 3 nerves and the 6 muscles. It's very common to have neuropathies, ocular neuropathies, and diabetic disease. And again, it's a small vessel disease, and some of the smallest vessels that we see in the body are in the eyes and in the nerves and the muscles that control that movement. So typically we'll see a 3rd, 4th, or 6th cranial nerve palsy. The eye will be in different directions of gaze depending on what's involved and which eye is involved. But diabetes is the underlying cause in more than a quarter of these in patients that are 45 years and older. So it's something that when patients come in complaining of sudden onset diplopia, it's something that's got to be foremost in our mind, is that potentially diabetes that's contributing to that. When you're checking pupils and we're looking at people, especially people that have double vision, your docs may tell you, don't dilate the pupil. If they come with double vision, don't dilate it until we see them, because we want to look at their pupils very, very carefully, because that's an important diagnostic feature. And it's got to do with how that 3rd cranial nerve, which both controls some extraocular muscle movement, but also the pupil, and how that is arranged. And so what we find is that the fibers that line the outside of that 3rd cranial nerve are responsible for pupil control, and the axons that are kind of down the heart of that nerve, in the center of that nerve, are the motor fibers. And so diabetic disease, because it's a small vessel disease, usually will spare the outer segment of that nerve and penetrate where those microvascular vessels go, will penetrate that, and that's where you'll have the pupil sparing. The pupil will be fine, and yet the 3rd nerve can be blown out. So most often in these situations, if it is diabetic related and it is microvascular disease, most often their recovery will be spontaneous, meaning without treatment, without intervention, and usually will occur within 2 to 3 months, where they'll recover nicely. So early in the talk, we looked at that angle structure, and I told you it was going to be important for later in the talk. There are areas, there are conditions sometimes where that angle is not open. It gets very narrowed and closed, and then the drainage area here actually gets pinched off or closed off. And that can happen in hyperopic eyes very commonly. Short axial length eyes are more prone to this. And it can be dynamic function that the fluid can't get through, and it can't drain, and the pressure can go up precipitously in these eyes. Well, that's not the mechanism for diabetic disease. That's what we see in typical angle closure disease. But in diabetic disease, we tend to see closure of that angle, but for a different reason. And that's because poor circulation from diabetes within the eye sends out chemical signals to other tissues, largely the iris, and it causes these new blood vessels to grow along the surface of the iris that you see on the left-hand side here. Sadly, this right-hand side of the slide doesn't project very well, but suffice it to say, these vessels will travel along and they'll make their way all the way to the angle, and then they'll fill the angle, which is where the drainage is, and they'll physically block it off. And so that's neovascular glaucoma as a consequence of diabetic disease. Can also happen from vein occlusion and artery occlusion as well. That can cause ischemia, and that can be very, very difficult to treat. This slide basically just depicts an angle that's involved with neovascular glaucoma and then shows you back to what our normal angle structures were before through a gonio lens. When we look at things like diabetic retinopathy, we see that that's a consequence of inflammatory mediators secondary to diabetic disease. And what it does is it causes endothelial compromise within the vascular wall. And so it has an adverse effect on circulation, but it can also make those vessels more permeable. So you have a situation where the retinal tissue, the retinal landscape is not being nourished well. Those tissues will send out chemical signals, and those chemical signals will be the genesis for new blood vessel growth, or angiogenesis as it's called. And those new blood vessels, you think, well, this is great. The tissue's starving for oxygen. We'll send vascularized blood there. We'll bring nourishment to that area, but the vessels are typically not patent. They're typically weak vessels. They tend to break and bleed easily, which is why you see hemorrhages in the retina and hemorrhages into the vitreous cavity as well, vitreous hemorrhages. So that can lead to this whole cycle of problems developing. Now, early on, you may just see that as small little intraretinal hemorrhages, or what we sometimes refer to as dot and blot hemorrhages. You can see exudates, which are leakages from the blood and the serum as well into the tissue. And that sets up this whole situation for compromised circulation and perfusion, leading to retinal ischemia. That can result in neovascularization of the retina elsewhere, as you'll see as NVE, neovascularization of the disc, which is often known as NVD, neovascularization of the iris, which I showed you on the previous slide, and then neovascularization of the angle, which ultimately leads to neovascular glaucoma. Can result, as I said earlier, in vitreous hemes, and ultimately into something known as proliferative vitreoretinopathy. We know diabetes has various stages: background, pre-proliferative. If there's cotton wool spots, which are basically retinal microinfarcts, those can occur, are neovascular changes, as we talked about. And then how do we go about managing these? So when we see things where we're seeing leakage or exudates, as you see here, little ballooning of vessel walls, aneurysms, cotton wool spots, little fluffy white spots that represent ischemia or lack of oxygen to the area, and then of course hemorrhages, which can occur as well. This is a clinical slide of that, with the fundus image on the left-hand side being a normal eye, and the clinical representation of what we're seeing between things like exudates, cotton wool spots, microaneurysms, dot and blot hemorrhages. All of those things are represented here on these slides. Another representation of much the same, although here you can see more bleeding inferior to the optic nerve here. And this is some of those fibrovascular changes I was talking about before, where you can actually get essentially scarring that occurs within the vitreous cavity and can pull on the retina, sometimes leading up to tractional retinal detachments. And then finally, as any of you that are involved in diagnostic testing have seen firsthand, I'm sure, is this issue of diabetic macular edema, where you can see these small little cystic spaces here that develop within the macular area. That's fluid that accumulates here. Here you're looking kind of en face or straight on. Here you're looking at a tangential cross section of it. And you see all these little vacuoles are fluid that causes disruption in the normal architecture. And it basically splays out the photoreceptors, which is why people can't see as well, and they see distorted images. So these are all the things that we hope to avoid. There are some things that can affect the optic nerve as well, with microvasculature to the optic nerve itself, resulting in things like anterior ischemic optic neuropathy, and so forth, all related to how the autoregulation of diabetes and the impact of the blood vessels that occur. And so you can see those structures here. The vasculature that's serving the anterior optic nerve can compromise it and cause damage to the optic nerve, which then impedes the signal to the brain. So a lot to throw at you. Diabetes is a complex disease. It's complex not only in its clinical ramifications, but it's oftentimes complex for patients to manage on their own. It's not an easy thing when we think about the choices we make by way of nourishment and food and how we eat and how we live our lives and stress and activity levels, all these things play a role. And diabetes, as we know, is on the rise. And we're going to see more and more of it in our clinical practice. So again, we appreciate everything you all do to help us get through our days and help us treat our patients well and determine what it is that's going on with them. And all these pre-testing things that are accomplished and all the diagnostic tests that you do really make all the difference in the world. So I thank you for your kind attention. I hope you have a nice rest of the afternoon.